Everyone, welcome to another video from BunMed. Today we will be focusing on hemolytic disease in hematology, and this part 1 video will focus on giving you an overview of the various diseases. In this case, we will be looking at the pathophysiology and linking this to the symptoms of a patient with hemolytic disease. And in part 2, we will focus more on the specific diseases, their diagnosis, and how they can be treated. So let's start off by thinking about what hemolytic disease is and trying to define it. And in this case, it's when a process, whether that be an external or internal process, results in the destruction or the lysis, which means splitting up of red blood cells. Now, as always, it's helpful to classify hemolytic disease in order to try and find out why a patient is having these symptoms. So the first way we can do it is through identifying if it's an immune-mediated or non-immune-mediated disease. And what I mean by this is that the patient may have an immune response to their red blood cells, which is causing the destruction of the red blood cells. However, it may also be non-immune. And an example here would be something like a heart valve, where mechanical heart valves can cause physical shearing of the red blood cells. Next, we have hereditary or acquired causes. So in the case of hereditary, this means that the disease has been inherited from the parents, and an example here would be something like G6PD deficiency. And this is an X-linked recessive condition in which a patient develops increased levels of oxidative stress due to the missing G6PD enzyme. Then we have acquired causes. An example here would be something like a blood transfusion where the patient has been given the incorrect blood due to an ABO mismatch causing antibodies to be produced against that blood, and therefore we have an acquired cause of hemolytic disease. The final way we can classify a hemolytic disease is whether it's intravascular or extravascular. And what this means is essentially refers to the location. So are the red blood cells being destroyed within the vasculature, or are they being destroyed outside of the vasculature? So in this case, it would refer to organs such as the spleen, the liver, and the bone marrow. And here you will find macrophages, which will result in the destruction and phagocytose those red blood cells. Okay, so let's start by moving into a case, and in this consideration we're going to be looking at a pragmatic approach. So we have a 58-year-old male who attends his GP complaining of feeling tired and short of breath. His wife also commented on his skin looking yellower than usual, and on further questioning you find that he has had darker urine and mentions there is some loss of appetite. So the question here is, what key information can you take from the history? What might you find on examination? And how could you investigate this patient? Of course, this is a slightly lengthy question, so if you'd like to pause the video and jot down a few notes, feel free to do so, and I will continue the video. Okay, so we do take some history, and then we start to think about examining the patient. And we find that on general inspection, we can confirm the patient is jaundiced. They have some scleral icterus and breathlessness on resting. They also have a lump on the left upper quadrant of the abdomen, and when you examine the abdomen, you find that this might be suggestive of splenomegaly. Okay, and then we do some investigations. So here are the investigations listed. Again, if you'd like to pause the video and have a think about what might be abnormal here and why it might be abnormal, so see if you can link it back to the pathology. And then we have on the right hand side a blood film of the patient. So think about what that might show you. Okay, and what I've done here is highlighted the main abnormalities, and we will focus on these in a moment. Okay, so starting off with a question, which of the following is the most likely diagnosis for this patient? Is it sickle cell disease, G6PD deficiency, autoimmune hemolytic anemia, or hereditary spherocytosis. Feel free to go back to the case and having a reread through it, and I will continue the video. Okay, so in this circumstance, the most likely diagnosis is autoimmune hemolytic anemia. Don't worry if you didn't get this correct, as we will go through the explanation now. Okay, so before we explore what autoimmune hemolytic disease is, let's think about the symptoms that our patient presented and why he might have presented with them. So here we have our trusty red blood cell, and unfortunately, for some reason, it's gone through hemolysis, and this can be any of the reasons that we discussed when looking at our classification method. Now, what will happen? Well, when the red blood cell undergoes hemolysis, it will release a number of substances alongside it. And the red blood cell contains things like hemoglobin, which of course is a very important protein for the transfer and transport of oxygen. And it will contain other things as well, like LDH and potassium. Now, if you remember, the investigation showed that the patient had a raised LDH. And so I've highlighted the key concepts of this slide in the red box for future reference as well. So the first thing we can think about is with increased hemolysis and increased destruction of the red blood cells, there will be an increase in the LDH released in the blood, and therefore this can be detected on laboratory assessment. Okay, now let's think about the hemoglobin. And as you probably know, hemoglobin is actually made up of a couple of things. So it has an iron molecule, which holds everything together, and then the other component is heme. Now, if we think about hemoglobin itself, the body doesn't like free hemoglobin, and it's actually toxic to the kidneys if it starts to build up. And therefore, some of that will be compensated by a protein called haptoglobin. And haptoglobin binds to free hemoglobin in order to prevent it from reaching toxic levels. Now, unfortunately, what can happen is that if there's too much hemolysis, then the haptoglobin is not in high enough levels, and therefore the hemoglobin will be released into the blood anyways. And so what we have is that the haptoglobin levels will be low because they will all be joined to a hemoglobin molecule, and therefore free haptoglobin levels are low. So that's the second point. We will have low haptoglobin levels in a patient who has hemolysis. Okay, now let's look at the iron component of the hemoglobin. What will happen to that? Well, normally what will happen is that we will have transferrin, which binds to oxygen in the blood, and the transferrin will take it to the bones where it can then be used to produce more red blood cells. However, in this circumstance, what happens is that because there is so much iron, again, the transferrin isn't able to keep up, and we have a lot of free iron available in the blood, and this may deposit in various areas of the body as well, for example. And this excess iron will result in a condition known as hemochromatosis. And because this iron is being released due to a secondary cause, which is the hemolysis in this case, this is known as secondary hemochromatosis. And this results in symptoms such as hair loss and joint pain. But other things include fatigue and the patient feeling tired as well. So that's our third point. Now let's look at the heme component of the hemoglobin. So what happens normally is that heme is broken down and processed or metabolized in the body to bilirubin. And again, if we have too much hemolysis, we will have a lot of bilirubin being released. And this bilirubin can deposit in various areas of the body, such as the eyes, causing scleral icterus, and the skin, causing jaundice. And additionally, the bilirubin can form clusters and form stones in the gallbladder, i.e. forming gallstones. And this may cause abdominal pain, specifically in the upper right quadrant. So that's our fourth point. Now let's look at how the bilirubin might also be processed further. And initially, when the bilirubin is released in the blood, it's in its unconjugated form, And what happens is that it becomes conjugated in the liver, and normally it would be released into the urine. Now again, because we have a lot of bilirubin, we're going to have a lot of conjugated bilirubin, and conjugated bilirubin, unlike unconjugated bilirubin, is water soluble, and therefore it will turn the urine darker. And that's our fifth point. Okay, and then we have this idea of intravascular versus extravascular disease. And the key concepts we've explored so far all refer to intravascular hemolysis. However, there are certain diseases which have a more extravascular component to them, and here we have the macrophages and the spleen again. And if the spleen is working overtime to try and destroy those red blood cells, it can cause splenomegaly, which is enlarging of the spleen. Finally, because there is a reduction in the number of red blood cells because they're being destroyed, the body will try to compensate by increasing the production of reticulocytes. And if you remember back to our patient, he had a high reticulocyte count, and this is the reason the body is trying to compensate. So you can see that the red boxes help to illustrate a summary of what might be happening in this patient and why. So we've tried to refer back to the patient's symptoms and explore them in more detail by linking them to the pathophysiology. Okay, so let's go back to our case and try to do that again. So we have this 50-year-old male who isn't particularly young, but at the same time isn't that old either. And he's got very non-specific symptoms of feeling tired and short of breath. Now, in this circumstance, and if you remember last week, we had a patient who had similar non-specific symptoms, and tired and feeling short of breath usually, or might in this case, indicate that the patient is anemic, which would fit in line with our diagnosis. Additionally, his wife complained of him looking more yellower than usual, and this is referring to the jaundice that this patient may have. And then he has the dark urine, which is referring to the idea of the unconjugated bilirubin being converted to conjugated in the liver, and therefore entering the urine and causing it to become darker. Finally, he has some loss of appetite. Now, loss of appetite can have a number of reasons as to why a patient may have it. This could be psychological, for example, if the patient has anxiety or depression. It could be related to a GI problem. But in this case, it's probably to do with the splenomegaly. So we found on examination that the patient has an enlarged spleen, and by pushing on the stomach, this may cause the patient to eat less, essentially. So the body is trying to adapt to that change. Now, these symptoms are actually for quite severe autoimmune hemolytic disease. Typically, this will present much more mildly. The patient may only have symptoms of mild anemia. However, it's a good case to illustrate the pathophysiology and the symptoms of the disease. Okay, now let's move on to the investigations. And we can see here that the key abnormalities is that, first of all, the patient is anemic, which we would expect because their red blood cells are being broken down quicker than they should be. And the other thing is that he has a high reticulocyte count. And as we saw in the previous slide, this is because the body is trying to compensate for that destruction of the red blood cells. His LDH and his bilirubin is high because of the hemolysis, and the haptoglobin is low because this will be binding to the free hemoglobin. And then we have this test called the Coombs test, and this was found to be positive. Now, the Coombs test is an important test when assessing if a patient has autoimmune hemolytic anemia because it identifies if the patient has antibodies against their own red blood cells. And so if this is positive, it highly suggests that it's an immune problem as opposed to a non-immune problem. Finally, we have something called Donarth-Landsteiner antibodies, and these are specific to cold autoimmune hemolytic anemia. So, in general, autoimmune hemolytic anemia can be split up into warm or cold. And in this circumstance, our patient had warm autoimmune hemolytic anemia. And the reason is because in cold autoimmune hemolytic anemia, the patient will typically present with symptoms in the cold, And additionally, they may present with something known as Raynaud's phenomenon. And this is where there is a change in the color of the fingers from white when the patient is in the cold to blue to red. And this is illustrating the fact that the vessels are going through spasm and it's affecting the blood flow to the fingers. And eventually, this will return back to normal. And so, if it's negative, it suggests that the disease is not related to cold cold autoimmune hemolytic anemia. So it's a good differential to rule out. And then we have the patient's blood film. And in this case, if we were to describe it, you would think about using words such as the fact that they are polychromasic. So what I mean by this is that they are different colors and they're also different sizes as well. And then we have the fact that they are spherical. So if we were to put everything together, this is a polychromatic blood film with spherocytes. And therefore, this is what you see in a warm autoimmune hemolytic anemia. Okay, so let's think about the treatment options that we have for this patient. And the first one would be to educate the patient and manage the underlying cause. So let's say this patient did have cold hemolytic anemia. We would be thinking about ways to explain that to the patient and tell them to make sure that they stay warm and that they wear gloves, etc., when going out in the cold. Then we can also think about medical therapy. So we can give the patients corticosteroids such as prednisolone, which will help to dampen down that immune system and therefore result in less hemolysis, hopefully. We can also consider giving the patient supportive blood transfusions because remember that they may be anemic, and therefore, by giving the blood transfusions, we can manage their symptoms of tiredness, breathlessness, tinnitus, arrhythmias, all of the other various symptoms a patient might have if they have anemia. We can also do something called plasmapheresis. Now, as you remember, autoimmune hemolytic anemia is a condition where there are antibodies targeted against the red blood cells. And so we can use machines to try and remove those antibodies against the red blood cells. And hopefully that would mean that the patient has less hemolysis. We can also step up treatment to things like rituximab, which is a anti-CD20 monoclonal antibody, and it can be given to patients, and again this will help to stop those antibodies from working and destroying the red blood cells. Finally, if there is an extravascular component to hemolysis, we can consider a splenectomy, and this will result in the patient not developing symptoms of splenomegaly, which may cause problems later on. Now, if we just give a brief recap of autoimmune hemolytic anemia, we can find that the warm hemolytic anemias typically occur because of IgG antibodies. And this has a variety of causes. And if you remember back to the lymphoma presentation, we did see that the patient had anemia, and this could be for a number of reasons, but there may be a autoimmune link to that as well. In the case of cold autoimmune hemolytic anemia, we have IgM antibodies, and one key association here is mycoplasma pneumonia. So, in an exam question, you might get a patient who, for example, has pneumonia, and then they develop symptoms of Raynaud's, and this could be associated with with them developing autoimmune hemolytic disease. Finally, remember that the Coombs test will be positive in these circumstances, as well as spherocytes. In cold IgM, you may also see something called agglutination, which is seen in cold IgM disease where there is autoimmune hemolytic anemia. Okay, thank you for watching. That was part 1 concluded. In part 2, we will focus more on the various classifications of the diseases and also focus more on the diseases themselves, including how to investigate and diagnose them. I've got a couple of examples of what we might be going through in part 2, but otherwise, thank you for watching, And if you found the video helpful, please do share it and consider subscribing to the channel.